I'm Suzanne James. Welcome to Nightshift, updating you on all things voluntary assisted dying in Australia. Those of you following will know that a number of states are having their statutory review this year, including Queensland, New South Wales and Tasmania. We'll be speaking today to Dr. Keith McArthur. He's a general practitioner who provides VAD consults to people in Tasmania and has been doing so for just over 3 years. Dr. McArthur joins us now from Tasmania. Keith, welcome.
Thank you. Good morning, Suzanne.
Please share with us how and why did you become involved in providing voluntary assisted dying services? Where does your interest in the field come from?
So I've been a doctor for over 40 years, most of that in a rural or regional general practice setting. We do or have done a lot of our own palliative care, and I've worked extensively in aged care homes. And over those 4 decades, I've looked after a lot of dying people, and some of whom don't die as well as they would like to, or as well as I would like to see them die. Some people, not many, but some have definitely asked if I can help, and then that has put us in a very difficult place.
Mm-hmm.
And up until VAD coming on board, the best we could do was educate them about their medication and their options, and if they chose to cease medications that were prolonging their life, then as they deteriorated, keep them comfortable with palliative care. And that journey could sometimes be a reasonably long journey, and that journey was not always a pleasant journey. So when VAD became available, I'm a proponent. So the why is because I believe everybody should be entitled to or able to have a peaceful, dignified death if they can and want.
What are the most common terminal diagnoses that you work with?
So the commonest terminal diagnosis would be the cancers. There's a lot of cancers, and I think about 70% of all applicants will have a cancer, and about 30% will either have neurodegenerative conditions such as Parkinson's disease or motor neuron disease, or other terminal conditions such as end-stage lung disease, heart disease, kidney disease, vascular disease, occasionally autoimmune diseases.
So during the consultations, of which there are several by the time a person's approved for VAD, what are the most common misconceptions patients sometimes have?
So mostly when a patient comes to me, they've already been seen and met a voluntary assisted dying navigator. The navigators are a group of 2 people that try to look after everybody in the state who's requesting VAD. And so a lot of the questions and misconceptions about the technical process, etc., the navigators have already reasonably addressed. I guess the common misconception I address is people often think there's a tablet that you can take, and there isn't. It's either a liquid or an injection.
I know in some states they're struggling with the issue of a person becoming unable to swallow and having to reapply then in order to have a doctor inject a substance. Is that the case in Tasmania?
That is very much the case in Tasmania. In Tasmania, if we want to change the medication, it needs to go through the commission, which takes some time. So I think often people are choosing to have the injection because there's a fear that if they become too unwell to swallow, that they then might miss out because of the time it takes to turn this around to give them an injection.
I guess that's something that will be raised in the upcoming review. What are the things you'd like to see taken into consideration?
So the Tasmanian legislation actually stipulates that for the medicine that is to be swallowed, if something doesn't go well, an unexpected complication, that the VAD doctor actually has a backup medication which will enable the patient to die more quickly. Even though that's in their legislation, it still doesn't exist. The Commission have not approved anything. That's not different to other states, but the other states don't have the law provision for it. So sometimes when people swallow the medicine, although they'll go to sleep within a short period of time, maybe 10 or 15 minutes, the time that it takes them to die may be prolonged. And in that situation, the doctor has to stay with the patient until they die. And rarely that can be some hours. We have to explain to the patients every time that even though the legislation says there is an option, that in fact there isn't. I particularly find that very distressing.
The other thing that doesn't yet exist, Keith, is the online portal that every
Yes,
other state and territory in Australia has, bar the Northern
yes,
Territory, of course. I understand from Mike Gaffney that they are working on that and that he's had a commitment from the government that it's going to go ahead, but hopefully it won't be too much longer. So exactly, there's a lot of data collection involved. I've had other doctors tell me in relation to
yes.
voluntary assisted dying, a lot of forms and a lot of admin and things that have to be filled in. So how much data exactly are you required to collect and how big a difference will this online portal make?
So my belief is portal will save considerable time. By the time the application gets put to the commission, there are up to 18 forms that have been filled in,
Sorry, how many?
two of which 18 forms, two of which the patient fills in, and all of the other forms the doctors are required to fill in. So these forms are emailed to us and they're in Adobe format and they're password protected. There can be problems with email addresses. Once you find it, you then have to go through the machinations of opening the email. The password, we know our own passwords, but for whatever reason, if I'm working on a computer that's not a government computer, I have to enter the password twice, once to open it, once to populate it. We then have to complete the form. And once we have finished completing it and saved it, if at a later date there are any questions, such as, oh, you tick the yes instead of the no box, or a daft one can be the patient, we have to declare when we took the first request and give a time. If I put 1100 hours and then accidentally tick the PM box, it'll get rejected because I've put 1100 hours as in AM and then tick the PM box. I
Okay.
can't fix that online. It's fixed by emails.
It's something that needs to be resolved with some urgency. So, how many hours over the life of a voluntary assisted dying application, given there's 18 forms and multiple consultations and you're in a rural area, how many hours do you anticipate roughly it takes you for each applicant?
So I've been giving this some thought. I would say the minimum for an applicant that's very straightforward would be 6 hours, of which half would be administrative, which is unpaid. When there is a more complex patient, then it can take more and more than 3 hours in just paperwork. Then there's also the fact that if we have to stay while the patient dies, and that takes a while. So the average patient, I would guesstimate at 6 hours, but sometimes it's more than 10 hours per patient to be their primary doctor.
So, under remuneration and difficulty recruiting doctors is a thing right across the country. I imagine you have the same difficulty in the absence of the portals, definitely not helping. What are the other things you think we can do to help increase the uptake of this as part of a GP's profession?
Um, so being able to use Medicare items for the consultation would be very useful. At the moment, there is some concern about whether you can or whether you can't. So I think a lot of GPs don't. I also know that there are some GPs in Tasmania that just do this all gratis. They do not want to have the concerns that Medicare might be upset by the fact that they're using item numbers for a consultation that could be around VAD. The Commonwealth have a criminal code. So a specific Medicare item number for VAD would be helpful. some form of payment for filling in the government forms would be helpful. If we are travelling, and often we would be travelling for 40 minutes to an hour, sometimes more each way, there is no remuneration for that. So at the moment, we're asking doctors to do this work, and whilst they are doing it, they are making less or no money compared to what they would be doing otherwise. And we're all busy. So a lot of doctors just can't afford to work in this space.
What's the blocker with the criminal code and the Medicare code?
So the criminal code is you're not allowed to use anything other than face-to-face to talk to a person about ending their life.
That's right, yes.
In simple terms. Medicare also don't want doctors to use Medicare item numbers if they're doing the same thing. It's not illegal to have the conversation, but it may be illegal to use a Medicare item number to bill for the time we spend in that.
But aren't you doing face-to-face consultations at present?
Yes. So it's not illegal to have the conversation, but it's not clear from Medicare whether it's legal to use a Medicare item number for the conversation.
With the patient when they're sitting in front of you at the practice? Okay, well, that's something else that we might have to put on the national board to be addressed.
Yeah.
All right, I'd like to ask you something a bit more personal now. How do you manage in general the emotional weight of working so closely with your terminally ill patients? Because you are in a rural area and in Tasmania and everybody knows everybody, and I'm guessing that you've probably, like a lot of family GPs, treated some of these people for many, many years. How do you personally deal with that? Do you feel you get sufficient support?
I think it takes a certain personality to be able to work in this space. I know many of my colleagues just can't imagine doing it. A philosophical approach. Life is a sexually transmitted condition that kills everybody. So they're all going to die.
Got to say, I've never heard it described like that before. Good on you.
I learned that from a wonderful professor of palliative care decades ago. So given that the person is going to die, and given that I'm probably going to be involved with their death at some level, given the fact that they are asking me to help them have a better death, and the amazing appreciation that comes from the patient and the family, that in itself is incredibly supportive.
Yeah.
Personally, I find this a warm space to work in. The comments from community, patients, friends, loved ones are always positive. And even in my normal day of general practice, a patient will come in and they knew somebody that had VAD and I was the doctor, and they have found out from the patient and they thank me.
Yeah, that's the same story I hear all over the country. And I'm having recently interviewed both Mike Gaffney and your president of Dying with Dignity, Bert Shug.
Yes.
They both impressed upon me how much Tasmanians appreciate the voluntary assisted dying legislation and how close it is held to their heart. What do you wish other doctors, policymakers, and the broader public better understood about voluntary assisted dying? What is it you want the broader community to hear?
Okay, so with the policy, there's a whole subsection on communicating to somebody about VAD, and it's written, in my view, back to front. It starts off saying a health professional cannot initiate a conversation about VAD, and then it has a few more lines, and then it uses, I think the words is in substance, and when you read it carefully, what it's saying is you can have the conversation and initiate VAD as long as it's a well-balanced, clinically appropriate setting. So last week I had a specialist physician talking with me, and 3 years down the track, they still believed that they were not allowed to initiate a conversation. the way the Tasmanian legislation is written, you have to read a good few lines before you actually see the qualifiers that say you can have the conversation. So I think that's important, and that would help doctors to understand they can initiate the conversation.
Yeah.
From doctors, what I would really like doctors to know is if they haven't done the VAD training, to not try to make any assessment as to whether the patient's eligible or not.
Yeah.
I have come across many patients now whose treating doctors have believed they weren't eligible, mostly because of the 6-month line in the sand. And then what happens is the patient may never get to make an application because they deteriorate too quickly, or when they do start making the application, they're too close to dying and they just can't get it through in time, or they lose capacity. So the 6 months part being removed, and non-qualified doctors not trying to judge whether somebody is eligible. If you're a non-qualified doctor and VAD comes up, just ask the patient to contact the navigators. Yeah, I think the 6 and the 12-month line are just restrictive obstructions that provide inequity.
And look, the gag clauses and the timeframes and the telehealth issue with the criminal code and Medicare, they're all historic things, you know, and I think it's time everybody accepted that they're antiquated. They're not working in the modern world, and it's now legal everywhere except the Northern Territory. And he's hoping that in the Tasmanian review this year, the committee, which according to all reports should give an excellent professional balanced outcome, will be able to take all those things into consideration. Well, thank you very much. You've been listening to Dr. Keith McArthur, who is a GP of many years' experience in Tasmania, who provides VAD consultations for people who wish to apply for voluntary assisted dying. You've been listening to Night Shift. I'm Suzanne James. Thank you for joining us.